So for my assessment portfolio, I chose to do a video to go through everything because I'm very much like a visual learner, so having a visual to look back on is what helps me. So I've been making videos throughout the semester, but to finish out the semester, I wanted to make one comprehensive video with everything from the toes to the hips. So my lovely roommate Riley has agreed to be my patient for this final one. So we're going to start with the toes. Okay, so first I'm going to have my patient seated with the foot off the end of the examination table. If I was using a goniometer, I would place the fulcrum on the medial side of the first MTP joint. I would have the stationary arm centered along the medial aspect of the first MTP bone and the movement arm centered on the first medial aspect of the first phalanx. And I would ask the patient to extend the toe up and then extend the toe down. So lift up your foot and extend it all the way down. Perfect. And flexion, a normative range is 0 to 30 and extension is 0 to 70. So then for passive range of motion, I would take my patient through it, lift it up, and extend it down. And again, the goniometer would be placed on that medial side. For resisted range of motion, I would simply have my patient place a single finger because you don't need all that much pressure, and ask them to go up, and then put the finger below and ask them to kind of curl their toes down. Perfect. So now we have rear foot inversion and eversion. So we have to lay your stomach. And for this, we would have the patient prone with the ankle or foot hanging off the end of the examination table. And then I would have the fulcrum over the Achilles. The stationary arm would be on the midline of the gastroc, and the movement arm would be centered along the midline of the calcaneus. And I would take the foot for eversion and take it out, and for inversion, take it in for passive range of motion. And for active range of motion, I would ask her to bring her ankle out towards the wall, and then bring her ankle in towards our stairs. Perfect. And then for resistant, I would simply apply a pressure to the calcaneus and ask her to resist against me as we go through the motion, so go towards the stairs. And then the opposite way, go towards the wall. Perfect. Normative ranges for that. For inversion is 0 to 30 and eversion is 0 to 5. Okay, so now I'm going to have you seated again. So for the tests, for ligamentous testing, we have the varus and valgus stress test. So the patient would be seated, and to apply a valgus stress, you would apply pressure on either side of the joint and bring it, pushing it so that it's applying a pressure towards the midline of the body. And then for a varus stress test, you would want to apply pressure on either side of the joint and apply it laterally to the body. And a positive test for that would be laxity or pain with that movement on the side that you are testing, not where your fingers are. So for an intermetatarsal glide test, we would have the patient seated with the foot off the examination table. You would stabilize the first metatarsal head, grab the second, and simply slide them. You repeat for each metatarsal, and a positive test would be pain with movement or increase or decrease glide when compared bilaterally. For a tarsometatarsal, you would also have them seated, one hand stabilizing the distal tarsal row and the other grasping the metatarsal, and you would glide between the tarsal and the metatarsal. Again, this is pain with movement or increased laxity when compared bilaterally. For a mid-tarsal glide test, you would have one hand grasping the plantar and dorsal aspect of one metatarsal and another grasping the opposite, or the neighboring tarsal, and you would glide between the two tarsals. There's not going to be a lot of movement there, but if there is excess movement or pain with that, that is a positive test. So for the feast line test, what you're going to do is you're going to draw a line from the base of the first metatarsal to the navicular tuberosity and to the base of the medial malleolus, and then you would assess the line. You would draw a line from the first metatarsal to the base of the medial malleolus, and if the line is above, it is indicative of pes catus. If it intersects, it's just a normal arch, and if the tubercle of the navicular is below that line, it is indicative of pes planus. For navicular drop, you would also have a line on that navicular tubercle, and you would take a note card and draw a line on the note card where the navicular tuberosity is. You'd ask your patient to stand, and then when they stand, you would see where that line drops to, draw a line on that note card, and assess whether it is 10 millimeters or more, and if so, that is indicative of pes planus feet. Of hyperpronated feet. For subtalar joint neutral, you would have the patient lying on their stomach, and essentially what you're looking for here is you're going to grasp that talar head, and you're going to move it until you feel that it is neutral between your fingers and even on both sides, and then you would evaluate the angle of the calcaneus to see the rear foot angle. Okay, you're good. In a non-weight-bearing position, we would have our patient, this is for pes planus and windlass, you would have them seated and ask them to do a heel raise, and you would look to see if the arch appears, and then put your foot down, and ask them to lift the big toe up.
This one's good at it.
Okay, the big toe up and see if the arch disappears, and if so, that is indicative of pes planus. For dorsiflexion eversion, we would have them seated again, and we would passively dorsiflex the foot and evert the calcaneus, and this is just to see if there is pain or paresthesia that goes into the foot, and that's indicative of tarsal tunnel. Long bone compression, one hand grasping the distal segment of the toe, and then you just apply an axial compression, and if that recreates symptoms or causes pain, that's indicative of a potential fracture. Mulder sign, so this is also known as, this is looking for an intermetatarsal neuroma, and you would use your thumb or forefinger to apply pressure over the space between the metatarsal heads and see if there's pain or reproduction of those metatarsal symptoms, of the intermetatarsal neuroma symptoms. And then we also have the interdigital neuroma test, also known as the eraser test. And this is where you would have the patient seated, and you would take an eraser or even your finger and place it between on the plantar side, and see if there's that recreation of pain or paresthesia, and that is also indicative of an intermetatarsal neuroma. Okay, so now we are doing the foot and lower leg, so the ankle and lower leg. So for this, I'm going to ask you, can you scoot so that your feet are up a little bit? Okay, just one's fine. So for this, I'm going to ask you to go into plantar flexion. So can you just push your foot down? Okay, and now I'm going to take, you can stop now, and I'm going to take you also into this plantar flexion. And then to do resisted range of motion, you would put your hand underneath and ask them to go through the range of motion while applying a pressure. Plantar flexion, the normative range is 0 to 50 degrees. And to assess this with a goniometer, you would have the fulcrum distal but in line with the lateral malleolus. You would have the stationary arm on the lateral midline of the fibula, and the movement arm will be parallel with the long axis of the fifth metatarsal. For dorsiflexion, the goniometer would be placed in the same place, and then you would ask them to lift your foot up for dorsiflexion. Okay, you can relax. And then for passive, you would take them into it, and then for resisted, apply a little pressure as they go through the full range of motion. Good. For inversion and eversion, you would have them sitting, and you would, for the goniometer, you have the fulcrum on the dorsum of the talocrural joint, centered between the two malleoli. The stationary arm will be centered over the long axis of the tibia, and the movement arm will be centered on the long axis of the second metatarsal. So it would all be on the front, and then you would ask them to bring their toes in. Perfect. And then for passive, you would do that, and then resisted, apply a pressure on the medial side. Perfect. And the normative range for that, for inversion, is 0 to 35. For eversion, it would be the same thing. You ask them to bring their toes out, making sure that they're not using their leg to assist them. And then for passive, you would stabilize that lower leg. And then for resisted, you would apply pressure on the lateral side and ask them to go through the range of motion. And normative range for that is 0 to 15 degrees. So now for the ligamentous testing. So for an anterior drawer to test for the ATFL integrity, you would put your hand underneath, ensuring and cupping to support the on your forearm, the foot. You're gonna grab that calcaneus and stabilize the lower leg and pull that leg forward, the calcaneus forward. If there is excess laxity or pain with that, that is indicative of an ATFL sprain. For talar tilt, you would have them seated as well, and in that same position of grasping the calcaneus and stabilizing the lower leg, you would bring the foot inward for talar tilt inversion, or outward for talar tilt eversion, and those are testing for inversion it is CFL, and for eversion it is damage to the deltoid ligament. For a distal tibiofibular joint play, and if you can get the fibula to glide anteriorly or posteriorly, and there's pain arising, that is positive for a sprain of the distal tibiofibular syndesmosis. Kliger says you would have them with their leg out, and you would simply stabilize and crank. And a positive for that is pain in the medial and anterior aspect of the foot, and that is indicative of a syndesmotic ankle sprain. For subtalar joint play, here you're looking for hypermobility or hypomobility, and you're looking to stabilize the talus and cup the calcaneus, and simply just kind of look at the amount of play you get, and this is very similar to medial subtalar joint play. For special tests, the squeeze test, so this would be something as simple as squeezing the metatarsals together. That is, if you do it like that, or if you do a long bone compression, that is looking for a fracture. If that causes pain, that is positive. For a bump test, you can bump on the bottom of the foot to look for pain that radiates throughout the entire lower leg, and that is looking for a fracture. The Thompson test. So, can you lie on your stomach? And with your foot hanging out, yeah. So for this, you simply are going to squeeze the calf, and if it causes the foot to rise up, that is a negative, because this is looking for an Achilles rupture, and if the Achilles is ruptured, the foot would not be getting movement. Then can you lay on your back? And then for Homan sign, this is looking for DVT. and you would have them with their leg extended, and you would push them into forced dorsiflexion. And if that causes pain, that's indicative of DVT, and you can also increase that pressure by squeezing the calf. Okay, on to the knee.
Woo!
So for knee extension, I'm going to keep you in this position.
Okay.
To look for range of motion, you would simply ask them to extend their knee, as she has already done here. For passive, I can pull her into that, and then resisted, just ask her to try and extend her knee. A way to look for hyperextension, which is very common in females, is to place your goniometer so that the fulcrum is aligned with the greater trochanter, or the fulcrum is centered over the lateral femoral condyle. The stationary arm is in line with the greater trochanter, and the movement arm is aligned with the medial malleolus. So that's going to get your range of motion. And then for flexion, so your stomach, you would have the fulcrum centered over the lateral femoral condyle. Again, the movement arm would be aligned with the lateral malleolus, and the stationary arm would be aligned with the greater trochanter. This is going to have a soft end feel just because it's going to end mostly with the calf coming in contact with the hamstring. So people with larger calves or larger hamstrings are going to appear to have less range of motion here, but a lot of the times you'll have to see like where their end range is because it might be due to their muscle. So for active range of motion, you're just going to ask them to bring their heel to their butt. Perfect. For passive, you would do it yourself. And then for resisted, you would ask them to just push against you as you go through that whole range of motion. Perfect. Alrighty, so now can you lay your stomach again? So for the special test, for this sweep test, so basically you're going to see if you can like pull the edema proximally and laterally, and to see if the curve of the medial aspect continues, and then apply pressure to the lateral aspect of the knee. And a positive test is if the fluid bulge immediately reappears on that medial aspect of the knee. And if that's positive, it's indicative of swelling within the joint capsule. So then we also have the ballotable patella. And so what you're going to do is you're essentially going to grasp the patella on either side, and using your finger, you're going to press that patella down. And if it kind of floats back up, or it takes a while for the fluid to refill, that is also indicative of severe joint effusion. So then posterior sag and quad active test. So you're basically going to have your patient with their leg up like this, and you're going to look at the levels. So put them both up, please. The levels of the tibial tuberosities compared to each other, and if one is sagging down, that is indicative of a ruptured PCL. And then if you ask them to contract their quad and the sag disappears, that is a positive test. So then Godfrey's 90-90 also is testing for PCL. So you're simply just going to put them into a 90-degree position instead of having them on the table, and look at the tibial tuberosity levels and see if they are equal or if one is sagging below the other. For posterior drawer, this is also looking for PCL. So you would have the foot like this. You're going to sit on their foot, find the tibial plateaus, and apply a pressure at the same angle the quad is coming up at. And then for anterior drawer, you do the same thing. You find that patellar or the tibial plateau, except this time you're going to pull anteriorly, and if there's excess laxity with that, that is indicative of an ACL sprain. And then for Lockman's, what you're going to do is you're going to have them with their knee extended, and if you have large enough hands, you can simply take them like this and pull them like that. But if not, you can bolster them. You can use your knee and then apply a pressure to keep the femur stabilized, and then try and draw that tibia to translate it anteriorly. And if you can, that is indicative of a sprain or tear of the ACL. So for valgus stress, you're going to take the leg and stabilize the tibia, and then you're going to apply on the joint line a stress medially to stress that MCL ligament. And if there's excess laxity when compared bilaterally, or pain on the MCL side, not where you're applying the pressure, that's indicative of an MCL sprain. And then a varus stress test, you're going to hold the foot like this, stabilize, and apply a pressure. And you're going to test these both at 30 degrees and at 0 degrees. And for the varus stress test, that is testing for LCL. So for the Slocum drawer test, there are a couple ways to do this, but one way that's really nice is you just put them back into that position with their knee up, and you turn their foot inward, and you sit on it again, and you do an anterior drawer. And for this, you are testing for anterior lateral instability, and when you do it posteriorly, that is for posterior medial instability. Then if you evert the foot, then you do an anterior drawer. That is testing for anterior medial instability. Then you do a posterior drawer, and that is anterior lateral instability. And then to do a pivot shift, this really only works in patients if they're unconscious, because people who are conscious won't relax enough to fully perform this test. But basically what you do is you're going to have them supine, and you're going to apply a valgus force and tibial internal rotation while flexing the knee. So you simply apply a valgus force and turn the knee in, and if that tibia and fibula do like a large shift onto that femur, then that is positive for an ACL tear. For crossover, for this one I'm going to do standing. So the crossover test is looking for anterior lateral rotation instability. So you're going to simply have them cross over and like sag into that. And if that causes pain and weakness and instability or apprehension, that is indicative of anterior lateral or anterior medial instability, depending on which side you have them on. So you can go back and lay back on your back. I'm good with that. So then looking at the dial test, so you're going to take the lower leg flex and rotate the tibia at 30 degrees and 90 degrees of flexion. So at 30 degrees of flexion, and you externally rotate the tibia, and then bent at 90, and you externally rotate that tibia. That is looking for posterior lateral instability or a PCL tear if at 90 degrees. 90 degrees is when the PCL tear would also be involved. So looking at the external rotation record bottom test, the examiner is going to lift up the leg of the patient approximately 12 inches off the observation table and look for just the alignment of the knee, and you're looking basically for hyperextension, external femoral rotation, varus alignment, and looking at those between the two knees for comparison. And then, okay, so looking for the meniscus. One of the most common ones is the McMurray's test. So we're going to have our proximal hand on the knee with the fingers palpating on that midline, and then you're going to take the foot and flex and extend the knee when in external rotation. So you're going to put the foot in external rotation, and you're going to flex and extend that knee. Then you're also going to put it into internal rotation and flex and extend that knee. And you're looking to see if there's popping, clicking, or locking of the knee. And if that is the case, that is indicative of a meniscal tear. Another way to do this is kind of to go into the figure 8. So you place your hands over that midline, you put them into external rotation, then you take them through the whole movement, and then put them into internal rotation and take them through that whole movement. Achilles compression. We're going to do bounce home first. So bounce home, you're going to take the foot like this, and you're going to talk to them, try and get them to relax as much as possible, and suddenly you're just going to remove your hand, and the knee is going to drop. And if that causes extension to be not complete or to feel rubbery, that is indicative of a meniscal tear. And then, can you lay your stomach? Achilles compression and extension, so this is also looking for meniscus tear. You're going to have them at 90 degrees. You're going to stabilize that femur, and you're going to grind their foot into the meniscus and see if that causes catching, popping, clicking, discomfort, or pain. And then distraction, you're going to pull the ankle up while stabilizing the femur. And if that causes relief, that again helps with indicating that there is a meniscus tear. Then for Thessaly's test, can you stand up? This is also known as the disco test. So you're going to have your patient with making sure that there's something that they can grab onto if they need to. They're going to lift up the unaffected leg, and they're going to twist and grind and go through the full range of motion.
Let me try
And basically, if that causes them to give out, that is indicative of a meniscal tear. So this is Noble's compression test. It's testing for the IT band. You're going to have your patient lying supine with the knee passively flexed to 90 degrees and the hip flexed at 45, so kind of around here. And then you're going to have your thumb apply pressure to the IT band while flexing and extending the knee. If there's pain reported over the lateral femoral condyle while the knee is at 30 degrees of flexion or around 30 degrees of flexion, that is a positive for IT band friction syndrome. Ober's test, you have them lying on their sides if you face that way. Standing behind the patient with one hand on the iliac crest and the other grasping the lower leg, you're going to pull that leg back towards you, and then you're going to let it drop. And if the pelvis moves forward before the leg becomes adducted, or the leg remains in a abducted position, that is positive for tight IT bands. And then Renee's test, you're going to stand. You're going to stand and apply pressure to the IT band at the femoral condyle and instruct the patient to do a mini squat. Okay, that's good. You can sit back down. And if that causes pain over that lateral femoral condyle, that is positive for IT band friction syndrome. Ligamentous testing, patellar glide. So, patellar glide test. So, so you're gonna lie down, stomach or back. So we want to maintain 30 degrees of flexion. So you can lie down or put your foot down. So approximately 30 degrees of flexion. And we want to gently push the patella medially to stress that lateral retinaculum and the lateral surface. And then you also want to push the patella medially so that it stresses the medial retinaculum. If the patella moves more than half of its width in either direction, it's hypermobile. And if it moves less than that, it is hypomobile. Hypermobile is laxity or restraints, and laxity, and then hypomobile is tightness. And then you're going to grasp the patella with your thumb and forefinger and try and lift the lateral border and depress the medial border. And if you get more than 15 degrees, it is hypermobile for a lateral tilt, and if it is less than 0 degrees, it's hypomobile for a lateral tilt. For the apprehension or Fairbanks test for the patella, you're simply going to have them supine with their knee extended, and you're going to gently push the patella laterally. Don't actually dislocate it, especially if you think that your patient has a continuously subluxing patella. But if you are pushing it laterally and they contract their quad, that is indicative of a possible patellar subluxation. So to test for a medial synovial plica, you will have their knee flexed at 90 degrees and their tibia internally rotated. One hand is going to passively move the patella medially while palpating the anterior medial side of the knee capsule. And then you're going to flex and extend the knee. And if that reproduces the symptoms or you feel the actual plica crossing over underneath your fingers, specifically between 60 and 45 degrees, that is indicative of a medial synovial plica. Clark's sign, I'm not going to actually do it to her because it hurts on everyone. But you would have them with their knee extended. You would put the web space of your hand so that it's grasping the foot or ankle, and then you would have, the superior pole of the patella, apply pressure downwards, and then you would ask them to contract their quad to try and pull that patella up against the articular cartilage. And it's looking for degeneration of the patellar cartilage, but most people are going to have pain with that, so it's not a very good test. The lateral pull test, so you're going to also have your patient supine with your knee extended, and then you're going to ask the athlete to contract their quads while you're watching the movement of the patella, and a positive test is if the patella moves laterally, and that is a test looking for maltracking the patella due to different dynamic forces. So for the stutter test, I'm going to have you seated with your legs off of here, please. This is also testing for a medial synovial plica. And you're going to have you're going to be lateral to the affected leg, so this is the affected leg. And then you're going to cup your hand over it without applying any pressure, and just ask them to extend their knee up. Perfect, you can put it back down. And if there's an irregular motion or actual stuttering between 45 and 60 degrees, that is indicative of a medial synovial plica. The McConnell test, so that's looking for maltracking of the patella. You're going to ask them to do it, so I'm just going to do it at 90, but you would do it at 120, 90, 60, 30, and 0. So you would ask them to do an isometric quad contraction, so can you just squeeze your quad right now? Ask them to hold that for 10 seconds. You can relax. If pain is felt, so what you're going to do is you're going to extend the knee, push the patella medially, put the knee back into the position it was, so in this case 90 degrees, and then ask them to do an isometric quad contraction. Thank you. And if that relieves the pain, then that is indicative of a maltracking patella. J sign, you're going to have them seated And then you're going to ask them to fully extend their knee. And you're going to ask them to slowly flex it. So, flex going down. Like move it down, yeah. Slowly flex it. And if there's like a sharp jump or the centering of the trochlea is late, then that is also indicative of a maltracking patella. And now we're on to the hip. Okay, so you're going to lie back on your back again. So looking for hip flexion, you would put if you're using a goniometer, you would put the fulcrum over the greater trochanter. You put the stationary arm down to the midline of the torso, and then you put the movement arm lateral to the femur and the lateral epicondyle. And then you would have them flex their hip. So.
Oh, like that?
Yeah.
Okay.
Okay, you can put it back down. So then, for passive range of motion for hip flexion, they would be supine with the knee in extension, and the patient's hands under your lumbar spine. Perfect. So I'm going to apply pressure to the ankle, and I'm going to stabilize their hand under the lumbar spine and flex that leg up. For resistant range of motion, you would be supine with the knee extended, stabilize at the ASIS, apply pressure to the distal thigh proximal to the knee joint, and ask to flex your knee, or your hip, sorry. Pull it up.
No, like this.
Yeah.
When do you remember all this?
And then, so you're going to lay on your stomach now. So, regular range of motion for hip flexion, knee extended, 0 to 90, and knee flexed, 120. So you can do it either way, but understand that the hamstrings will play a part in what the number of degrees you get. So for hip flexion, or hip extension, the fulcrum would be over the greater trochanter, the stationary arm would be the midline of the pelvis and the torso, and the movement arm would be the lateral femur through the lateral epicondyle. And then ensuring that they don't bring their hips up, you ask them to extend their hips, so try and pull your leg up. Perfect. And then you would get between 0 and 30 degrees in the normative range. For passive, you stabilize over the PSIS, grasp the anterior knee joint, and bring them up as far as you can. And then resisted range of motion, you would stabilize over the PSIS, place your hand over the posterior aspect of the hamstring and ask them to pull up. Perfect. For hip abduction, so flip over again, sorry.
You're good.
The fulcrum would be over the ASIS. The stationary arm would be on the distal end opposite to the ASIS, and the movement arm would be on the long axis of the anterior femur through the mid-patella. And then you would ask them to pull your leg out as far as you can. Perfect. And then if you could lie on your side with this leg up, you would take them and you would pull them into abduction, and then for resisted, stabilize, put your hand here and ask them to lift your leg up. Perfect. For hip adduction, you're going to have them on their back and fulcrum over the ASIS, distal end opposite to the ASIS, and the movement arm on the long axis. Again, and then you're going to ask them to bring your leg across you as far as you can. Yeah. for hip, and then you would also have them for passive supine. You would want the opposite hip and knee flexed and crossed over so that the foot is flat on the table, exactly, and then pull them into as much adduction as you can. And then for resisted, you stabilize and ask them to pull in and go through the full range of motion. And then can you come seated for me? For hip internal rotation, you're going to have them seated with their knees flexed over the examination table. The fulcrum will be on the center of the patella. The stationary arm will be perpendicular to the floor. And the movement arm will be centered over the anterior tibial shaft. So then you would ask them for hip internal rotation, you're going to have them externally rotate their lower leg. So bring your leg out as much as you can. Okay? And then you're going to bring it out passively, applying that overpressure. And then resisted, you're going to ask them to go through that full range of motion. Good. Normative range for this is 0 to 45 degrees. And then for hip external rotation, you're going to go through the same thing with the fulcrum over the center of the patella, the stationary arm perpendicular to the floor, and the movement arm on the centered on the anterior shaft of the tibia. And you're going to have them for external rotation of the hip, it's internal rotation of the lower leg, so ask them to pull their leg towards, and then for passive, you just apply an overpressure, and then for resisted, apply a pressure on the medial side as they go through the full range of motion. Normative range for this is also 0 to 45 degrees. So then, also in the seated position for special test, for the fulcrum test, we are looking for femoral neck stress fracture, and you're simply going to place your hand or forearm under the patient's knee, and then you would apply a pressure to the top of the knee, and if that causes pain when the pressure is applied, that's where you're going to suspect a femoral neck stress fracture. For femoral nerve traction test, I'm going to have you side lie with your, this way. This way? Other way. Okay. This way. Okay, so for this, you're testing for issues with the femoral nerve. So you're going to have them flex their neck, and then you're going to take that leg and pull it back, making sure the hips are stacked and stabilized. And if that causes pain or paresthesia in the anterior or lateral hip and thigh, that is positive for nerve root impingement of L2, 3, and 4. Then can you lay on your back? For patella pubic percussion, you'd have them with their knees extended, and this is also looking for a patellar neck, a femoral neck stress fracture. You would place the head of the stethoscope right over the pubic bone, and you would have the stethoscope in, and then you would ask the patient to hold the stethoscope right there, and then you would tap both patellas, and if one is more dull, if you notice just a difference in the sounds, that is indicative of a femoral neck stress fracture. So I'm going to have you flip over. So this is Eli's test. So this is looking for quad tightness. So you're simply just going to take the foot and bring it back as far as you can and take it through that passive range of motion of knee flexion. And if it causes the ipsilateral side of the hip to rise up, that is indicative of a tightness of the rectus femoris muscle. So then you can flip back over. So standing at the patient's feet, you're going to ask the patient to squeeze up. So extend your legs and then try and squeeze as hard as you can. Squeeze, 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 squeeze. Okay. And if that hurts, that like deep in the hips, that is indicative of athletic myalgia. Can you pull your knees to your chest?
Yes.
And then I'm going to take this one and then turn you a little bit off the table. So I don't have a treatment table, sorry. But you would release one and observe the hip and knee position. And if the upper thigh doesn't come in contact with the table or isn't parallel to the floor, that is indicative of tightness of the iliopsoas. And then if the knee remains extended rather than flexed, that is indicative of the tightness of the rectus femoris. Okay, you're good. And then I'm going to have you stand up. So this is called Trendelenburg's test. And what you're going to do is ask your patient to lift one leg up. And if they stay stable, that's good. But a positive test is if they stick their hip out and look all sassy, then that is weakness of the gluteus medius. Next, we're going to do the piriformis test. So can you lie on your side? So this is the piriformis test. And we're going to place a hand on the iliac crest and the other on the lateral side of the knee. And you're going to flex the knee and straighten this leg. And then we're going to apply pressure to the knee to stress that piriformis. And if there's excess tightness when compared bilaterally, pain or reproduction of symptoms, that's indicative of piriformis syndrome. And then Ober's test, so we're also going to have them sideline with the test side up. We're going to stand behind the patient with one hand on the iliac crest, and we're going to allow the patient to have their hip adduct as far as it can. And then if the pelvis moves before the adducted leg, when it still is abducted, that is tightness of the TFL. So now I'm going to have you on your back again. So now this is looking for femoral acetabular impingement or labral tears. So this is the Fader test. So we're going to have the patient laying supine, and we're going to stand next to the patient and internally rotate the leg, as the name implies. So it's adduction and internal rotation. So adduction and internal rotation. And we're going to take them through that movement. And if there is pain here, you would stop. And if not, you would apply an axial load. And if that causes pain, then that is indicative of femoral acetabular impingement. And then for Faber, we would have them, we would do a abduction and external rotation. So you would have them go into a figure 4 position and then apply another axial load if that is not painful as is. And then the hip scouring. So this is looking for the labral tear. You would have the patient supine, and you would internally rotate the leg and apply an axial load, and externally rotate and apply an axial load. So this is kind of like Ackley's compression, looking for a labral tear this time. And now we are going into the neurovascular testing. So if you come seated. So when looking at L1, for the myotomes, that would be right below the inguinal line. And then L2 is the band just beneath the mid-thigh. And to test for the myotome, that would be hip flexion. So you would have them flex their knee. For L3 dermatome, it would be the band just above the patella. And for the myotome, it would be knee extension. So extension of the knee, perfect. L4 is the medial lower leg and into the medial foot. And this would, for the myotome, would be dorsiflexion, so lifting the toe up. And the reflex testing would be the patellar, so you do that, and if they kick out, that's positive. L5 is lateral lower leg and the dorsum of the foot. And then this is plantar flexion, so if you can put your toes down. And then this is the medial hamstring, would be your reflex, so tapping behind the medial hamstring while they are prone. S1 is the lateral foot, and, this one is plantar flexion. L5 is great toe extension, so this is plantar flexion. And the reflex for this would be the Achilles, so you would hold the bottom of their foot, tap the Achilles, and if you get the foot to plantar flex, that is a positive reflex. And then S2 would be the posterior thigh and the popliteal fossa, so that area right behind the knee. And the movement is knee flexion, so that would be bringing the knee back towards themselves. Perfect. And the reflex would be a lateral hamstring, so while they're prone, tapping that lateral hamstring and having that contract. And then S3 would be your iliac crest. And so then your myotones would be foot intrinsic, so if you can like arch your foot, that is a positive. We are all done.